DLDR spine surgery that replaces fusion, replaces microdiscectomy, laminectomy, and pretty much any other surgery for back pain or leg pain. The surgery is done with a small 7mm incision, minimally invasive, much less invasive than any other spine surgery out there. And our patients have only a few drops of blood loss. Our patient today is having bilateral surgery, meaning on both sides. He's had prior surgery in his back before. Are you awake? All right, Dr. Duke here. We're going to get started. I'm going to start by giving you some numbing medicine, okay? If you feel pain, you just say, ouch, and I'll give you more numbing medicine. But don't try to get off the table and move, all right? We're going to put you to sleep in a few minutes, but I need you awake right now. All right, just a little stick and burn. This is numbing medicine going in. I apologize, it's uncomfortable. Yeah, thank you for telling me. All right. And now the other side, you'll feel the same thing, okay? A little stick and burn. I apologize. That's going to be one of the worst parts of the surgery right there. Yeah, I know. Just bear with me. All right. Just lay still. You're doing great. We're going to put you to sleep soon. So our patient has had back surgery before at L5-S1 and unfortunately developed an infection. The surgery was not done by me. It was done elsewhere. And he had to be treated with antibiotics. Ultimately, L5-S1, those two bones fused together as a result of that infection. Now he has what's called adjacent segment disease, where he's developing pain adjacent to his old surgery. We're going to be using the X-ray machine to take some pictures in a moment to guide me to the proper disc, which is L4-5. Okay, that's a little better, but you're still rotated. Is he laying flat on the table? He looks like he's airplane towards me. Shot? Let me know what he's saying because I can't hear him. Lateral view. You went the wrong way there, Jordan. I'm not sure what you're doing, but it's worse. What's he saying? Table up, please. He wants to adjust the head. No problem. Go ahead and work with the anesthesiologist to get comfortable. And shot. All right, I need you to come south a smidgen, 1/4 inch to 1/2 inch max. Shot. Now let's go ahead and get that L4-5 segment. Yeah, I need higher on the table by 1/2 inch. That's good. Let's get the 4-5 wagged in properly. So I'm working with my team right now to try to get the X-ray machine lined up. Worse. Let's go the other way. I think you have leg squeezers on, right? You need to move south with the fluoro. Uh-huh. And move north a little bit. You're doing fine. That's just me. I apologize. All right, we can do better than that. Let's get that disc space lined up again. You had it there a minute ago. You just need about 3 or 4 degrees of arc. That's good right there. Your feet are not better? Shot. So our trajectory is good. We're just encountering the facet joint. What is it? Shot. How's our blood pressure? Blood pressure. All right. Let's try to get it down just a little bit. Shot. Which leg bothers you more, Shot? The left leg. Shot. All right, we're making our way around the facet. Shot. Perfect. Where do you feel that? I can't hear you. Where?
In the back.
Perfect.
Nothing going down the leg, right?
Yeah, we found your first herniation, okay? That's the good news. And we've had one drop of blood loss. That's it. Are you comfortable? Huh? It depends on how we define comfortable, right? We'll get there. Your nose is getting stiff? Do you have sinus issues? Do you have allergies, sinus allergies? You do? Shot. I know I do. I just had sinus surgery. Are you having trouble breathing through your nose? Have you always had that? Is that just here in Florida? Just now. Okay. All right. Is that my picture there? All right. By the way, everything is going perfect. Shot. Shot. Yeah, I know it's uncomfortable, but we're going to be done soon. Don't worry. Shot. And we're going to put you to sleep, okay? Shot. Shot. Where do you feel that? Okay, where in your right leg? By the calf. Give me an AP. Do you still feel it? Is it like pain down your calf? Move that, please. Well, there is a squeezer on your calf. Is it something different? You don't feel it?
Oh, sir, do you still feeling that squeezing on the calf?
The left? The left?
No, he said on the left.
Oh, that's the leg squeezer. Go back to a lateral, please. Your AP is horrible. Can you do better than that, Jordan? Come on. You shouldn't be happy with that.
No, those are to keep the blood flowing. Okay, that is just to prevent blood clots.
So you don't get a DVT.
Correct.
Pulmonary embolism. Shot. Are you comfortable? Just lay still. All right, we're almost done. We're going to put you to sleep soon, okay? Did you have much back pain? Huh? No, but do you have back pain every day?
Oh, sir, do you have back pain every day?
He does. He does. I want him to think about it. Where do you have that pain? In the back. How bad is it on a scale of 1 to 10? Is that where you typically have your back pain? Is that where you typically have your back pain? All right. 42 what? Just lay still. You're doing really good. We're almost going to put you to sleep now. Was that where you typically have back pain in your back? No. Where do you typically have pain? Well, that's your bad disc. That's the L4-5. Let's just get a view lower and make sure. This cable is getting stuck on my... Can you bring the fluoro a little bit lower? Clip it up there. I don't see anything besides this that's fused. Come on. Cam, you don't see the cables in the way? Shot. All right, we're ready to put him to sleep. I want you to count from 1 to 100. You can count in Spanish if you like, or English, whatever is best for you. Start with 1.
That's fine. Just keep breathing. I'll help you with.
Count from 1 to 100. Did you get the AP? You need the AP and lateral discogram. Don't bother locking your fluoro. It's a waste of time. Just get it into the AP, take the picture, and then move back to a lateral. All right, that's fine. You're doing great. Keep counting. How's blood pressure? Good? Shot. Keep going. You're doing really good. Shot. So we're going to start with the left L4-5 disc. And like I said before, he's had surgery at L5-S1, microdiscectomy, not by me, by someone else, and he had an infection. And that infection could have killed him. We've had 0 infections with the surgery you're watching now, but his old surgery was done here in the middle. And it was done by a spine surgeon with a microdiscectomy, which is the typical type of surgery. We don't use this kind of blade. Why do we even have this blade on the field? It's an 11 blade, Luis. Come on. Let's not make silly mistakes. Who set this case up? But you know better than that. We always do an 11. How did you end up with a 10 blade?
That was my fault, sir.
All right. Let's not make mistakes like that. They're costly. They waste time. They waste resources. I understand it's your fault. Why don't you go in there with them, see where the blade is, so the next time you'll be able to find it. How's he doing? All right, so we're doing bilateral, this patient at L4-5, because he has leg pain on both sides. If he only had leg pain on the left, we would only be doing the left side. I only go on the side for the lower back where patients have either symptoms or exam findings of weakness, numbness, reflex changes, basically where they have a radiculopathy. Most patients only have one leg that bothers them, so we only go on one side. But a few patients, about 5%, 1 in 20, 1 in 10, so 5 to 10% of patients will have both legs bothering them. And we have to go on both sides, okay? Interesting. Just put a little pressure here, right here on the muscle, about that much pressure. Thanks. I'm going to make the incision right along the guide wire. Okay, it's 7 millimeters. That's how big this incision is. That's as wide as the tube that we're going to do the whole surgery through. Okay, so the first thing I do is I bring my dilator down over, and I know we're passing through muscle and fascia, and then we're going to get right into the foramen where the herniation is. Shot. Blood pressure is good, yes? All right, so the dilator is moving down the guide wire. Now, I'm not the first surgeon in the world to make a dilator guide wire type of procedure. This is something in terms of dilators and guide wires. I was taught this in residency. We started doing what are called percutaneous screws, pedicle screws, when I was a resident. Shot? And percutaneous screws are basically screws that are put through the skin using guide wires, just like I'm doing now. Except I'm not putting a screw. I'm putting a tube, a cannula. Okay? So just so you know, the entire surgery here will be done with this tube. Okay? This tube. Our patient is actually a physician, and we were chatting a little bit. I can't give you too much information about him, but he certainly didn't want to have the kind of experience he had last time when he had a microdiscectomy at L5-S1 that became infected. Shot? So he watched the Duke laser disc repair procedure and shot, and this is what he wanted done. He didn't want open surgery done. He wanted endoscopic spine surgery. Shot? All right, good. So I'm in the disc. We're going to go ahead and get the dilator out. Cam, you got to learn where to put your sharps so they don't put you at risk or anyone at risk, okay? Otherwise, you're going to be up here grabbing things, and you're going to stick your finger with a needle or a blade. Okay, so learn early on about safety, know where everything is, put things in such a way that you won't poke yourself accidentally as you're reaching around. And I would put them in a specific area of your Mayo tray. Okay, it's a good habit. You know how you put your toothbrush in the same place when you're done? Every morning? You put your brush, your hairbrush in the same place? You put your shampoo back on the same place. It's no different in an operating room. You want to develop habits that make sense, okay? That enhance safety and efficiency. All right, so we're ready to get started. We're going to open our irrigation channel, and we're going to go down this tube, and we're going to hopefully find, my staff will turn my, guys, come on, try to keep up here. Let's move that light back so I can see the monitor. Why is the endoscopy tower here?
Because of bilateral. Then you need a...
All right, it's fine. I need to see what I'm doing, guys, up here.
It's fine.
All right, any questions from our audience?
None so far.
There should be a piece of herniation there. All right, I need to see what I'm doing up on the monitor. Why do we not have the monitor up? Guys, that should have been addressed right away in the very beginning before we even got started. Luis.
I cannot see the feed from the endoscope either.
What's that?
We cannot see the feed from the endoscope in here either.
Neither do I. It's because there is no feed from the endoscope. Because we sat on our thumbs and twiddled our thumbs up our assholes while we were all waiting, Googling and masturbating here in the operating room, self-stimulating. Meanwhile, nobody bothered to plug in the endoscopy source. Anybody ever watch Willy Wonka and the Chocolate Factory? We all watch that movie and we think, my God, the Oompa Loompas are weird. But you know what? They're not so weird. They're actually the perfect workforce because they don't make mistakes. They stay focused. They stay on task. They're efficient. Unfortunately, I have to deal with human beings. We all make mistakes, even myself. I'm not perfect by any means. But Willy Wonka had the perfect employees. No one called out sick. No one missed work. No one was late. No one made a mistake. No one held up the chocolate factory. That book was written over 100 years ago. All right, so we're still sitting here doing nothing at this point while we're waiting to get our feed from the endoscopic tower over to the television so I could see what I'm doing. Has anyone called Sonny yet? Let's turn the scope off for a moment.
Scope off.
Tell me that the box have a red light instead of the green light.
All right, I apologize for the interruption, but we're sitting here waiting for the feed, the live feed from the endoscope to reach our monitor so I can see as well. It's not just you that can't see.
Louise, have you checked all the connections?
Yeah, we check still red, so we put it directly to the wall. We just use that box.
All right, we're back online, and we shall proceed.
Yeah, I'm good. Yeah.
All right, so we're going to get started. Nope. I'm inside the disc. I want to use the laser at this point. So we're going to get the laser fiber in and get started. Where's my pedal? Good. The laser is the blue wire. Hello, get the laser on. I'll need a blanket on the floor. There's a lot of water here. Or you could just leave it so maybe I could trip and fall and hit my head and not have to come back to work for a while.
What you say, sir? I'm sorry, what you say?
Stable, laser off, hold. Let me have this. Okay, we good? I would just put a blanket down there and soak up the water. You know. All right, Cam. Try to get you some fragments of herniated disc.
Sounds good.
We do our videos live, that way everyone can kind of watch and participate in the surgery as it's happening, including the bad parts where we struggle due to our humanity. Here. All right. That is the tear right there, the annular tear, you can kind of see. And I'm going to use the laser to debride the annular tear. That's really the primary goal of the surgery. Is Duke laser disc repair is the first and only surgery in the world to do what's called an annular debridement. There is no other surgery in the world that does an annular debridement. And as such, it's the only surgery that really treats the source of back pain or neck pain from a herniated disc. Do not let that blue cable flip and hit you in the face or go anywhere to get contaminated. Okay? That's one of the few things you gotta make sure never happens. I would advise you to move those pieces to the side and have a clean, these are all pieces of herniated disc, by the way. Have a clean catchment area on your Raytech, like I've told you before. Otherwise, you're going to start putting pieces back onto my grabber, and I'm going to put them back in the patient. Does that make sense? It's kind of like if you're wiping your face and getting the mud and dirt off your face from being outside in the dirt, and you keep wiping your face with a dirty napkin, you're just going to keep smearing the dirt on your face rather than cleaning it. Okay? It's no different when you're grabbing pieces of disc material off of a surgical instrument. You're just going to keep smearing them on the instrument. I don't want to mention it again, Cam. So start figuring out how you can fix that. Ask Luis if you need to. All right, our laser is a medical laser. It's a holmium YAG laser. There is no other laser available in the world that's better than this laser for this application. Are there other lasers available in medicine? 100% yes. CO2 lasers are available. There's a variety of lasers that are available. Are those lasers better than the one I'm using? Absolutely not. We didn't pick this laser because it was the cheapest laser. We picked it because it's the right laser for this application. And this is what I've used now for 15 years of doing this surgery. This is all herniated fragment right here. I'm just freeing it up. It's stuck down to the disc, stuck to the annular tear from inflammation. Standby laser. The last time I talked to you all, it was a few weeks ago. I told you that would be the last time you hear my voice like that. The reason is I ended up having my sinuses and septum operated on. I had surgery myself. It was endoscopic surgery. Look at that herniation right there. Oh yeah, that's a biggie. Woo! All right, so let's take a look. Come on, Sean. Come into the overhead. Look at the size of this herniation.
We can see it.
I need like a towel, or put the Raytech here, please. Look at this thing, okay? Put your thumb there. Look at the size of this herniation. That came out of the patient's left side. That is a disc herniation. Go ahead and take it. That's my little gift to you, okay? Don't say I never gave you anything, Cam. So you see how monstrous that thing was. We don't get a lot of those. Most of the time it's little pieces. So I'm happy to have that. That was like finding finding some gold if you were digging for gold, right, Doctor Santiago? Diamond. That was like a piece of diamond there. That was a beautiful. That's what was pushing on his nerve on the left side. Now there's a few other little pieces, but nothing anything near that big. But we are going to clean the tear up, because if I don't clean this tear and debride it, he'll still have back pain from this disc.
That's probably the patient's phone number. He gave me his
His cell?
cell phone.
Oh, he's getting a phone call.
No, it's an alarm.
Oh, an alarm? So he gave you a cell phone and there's an alarm.
Yes.
There's not a countdown though, it's just an alarm, right? And it's not working. All right, it looks like there may be another piece of herniation right there. So this poor man had 2 giant herniations, probably 2 giant ones. All right, let's just send his phone out of the operating room, please, because I don't want to listen to that. It's very distracting. Uh-huh. All right, fine. Just lower the volume. All right, so we may actually have another piece. I don't think it's going to be quite as big, but it's a good size one still. Standby laser. And we have a tech who's here helping us today on the laser. Okay, there's a piece. Not quite as big, but still respectable. And anybody know what that tech's name is? I'm not asking the people in the operating room. What is the name of our laser tech? I'll give you a hint. It's a female. She works in my clinic. She's a redhead. Anyone who said Hazel did a great job, you got it. Hazel's here working the laser. And every time I come out and I bring the laser out, she has to turn the laser machine on pause. And the reason for that is if inadvertently I were to step on the pedal and start shooting the laser around the room, it would be like Star Wars. We got Chewbacca right here next to me. Cam is like 7 feet tall. I mean that in a good way, Cam. In a loving way. He doesn't have as much hair as Chewbacca, but he's got a sweet personality like Chewbacca. I don't want to see him get angry though. We got Han Solo and Princess Leia. But seriously, the laser would zap around the room, could get into somebody's eye and cause an injury. These lasers, when they're up close, they can deliver a lot of energy and they can actually melt steel. Okay. So they're very powerful. I used to talk to patients about this surgery years ago and they would say, well, how can you get the bone spurs? And I say, with the laser, but the laser can't get bone spurs, can it? I said, who told you that? Oh, the guy down the street who doesn't do laser surgery told me. Oh, really? Well, how would he know if he doesn't do laser surgery, right? No, of course the laser can go through steel. No problem. We're actually using it at 30 watts. And this thing goes up to 100. And this 30 watts will melt the steel. So you can imagine what 80 watts would do. Or 90 watts, 3 times the energy. You see all the blast marks on the tube over there, right by the laser, just behind it on the steel? Those are melting, steel melt marks from the laser hitting it. Just one blast. Each blast delivers enough energy to melt the surface of the steel. So getting rid of a bone spur, which is easy compared to melting steel. That's why we don't ever go higher than 30. 30 is our maximum. We do 15 joules, right? Is it 15? Sorry, 2 joules of 15 hertz, which gives you 30 watts. Okay? Joules times hertz equals watts. Watts is work, electrical work. Joules is a measure of energy. Watts is a measure of work. Energy over time equals work. All right, this is still herniation right here, just starting to squeeze out. Now the reason why things are shaking and wiggling, 2 reasons. One, every time the laser blasts, it releases a pulse wave, a pressure wave. So you see everything jiggle around from that. And then also we have liquid going through the tube. You don't work with Cuppinger, right? You told me that. I heard that Dr. Malloy is down there now. He's a neurosurgeon from down in that area, Fort Pierce. He was recruited up here by 2 people whose names shall go unmentioned. Remember? And the other day I saw a person who works in the office that Malloy was working, and they said they hadn't seen him in a long time, like 6 months. So I was just wondering if you had heard anything. You don't work with the guy, I take it. Just about done here. I'm lateral right now in the disc. So for those of you who were here earlier today, we did an anterior cervical discectomy and fusion, ACDF, 3 levels, C 4, 5, 5, 6, 6, 7, for 3 herniations. Our patient is doing well. She's having some muscle spasms from the surgery in the back of her neck, which is normal. But other than that, she's ready to go home. And the surgery went well. She did well. And this is our second surgery for the day. This is the Duke laser disc repair, bilateral L4-5. And I am just about done with the left side. I'm going to move to the right in just a minute. Down here, we should probably find the other needle very soon. We're going to find the tip of the needle because we have one on each side, right? This is the annular tear. That's the fibers of the posterior ligament there. This stuff right here is the foraminal ligament. It's very white. But this is the tear right here, right where I'm on. And I'm trying to debride as much of it as I can so it heals properly. The reason you do the debridement is to get rid of the back pain and also to let the annulus heal so another herniation won't come. It takes a long time for the annulus to heal. There's no way for me to accelerate that. There's something I'm thinking about developing to accelerate it, but I haven't finalized the idea yet. But if I could get this to accelerate its healing and people can go back to more regular activities faster, and there's a lower chance of reherniation, hopefully. Our reherniation rate right now is about 1%, maybe a little bit more, like 1.1%. That means 1 in 100 patients will have another herniation after the surgery. It's always related to some type of movement of the back or the neck they shouldn't be doing, usually lifting something heavy or twisting or bending. Many of the patients feel so good within a few days of the surgery, they think because they're feeling good they can do what they want, but unfortunately the disc is not healed and they need to give it time to heal. And like I said, the disc heals very slowly because there's no blood supply to the disc. Everything that the disc gets from the outer annulus has a blood supply, but the inner annulus does not. And the annulus is what must heal. So the blood supply is very poor. Look, right now we're cutting all this stuff out. You don't see any bleeding. You don't see bleeding because there's very little blood supply.
We have a question.
Yeah.
One of our viewers who joined us on the last stream as well asks, is what we're looking at right now the same stuff that you removed, the stuff you said looked like,
Yes.
yeah, the
Yes.
jelly?
So the viewer is saying to me, hey, what you're removing right now, is that the same as the crab meat that we took out in the earlier case with ACDF? The answer is yes. The crab meat is the nucleus pulposus, okay? And that's exactly what we're taking out with the laser. It doesn't look exactly the same, but that's what we're dealing with. It's pretty close looking. But we're inside the disc with a scope right now. So the nice thing is, because of the way I'm doing this, we don't have to do a fusion because I'm not taking the whole disc out. I'm only taking a little piece out and I'm cleaning up the annular tear. Now I bet you if I were to advance the other needle a little bit more, maybe we would see it in there. No. Well, it's in there somewhere. We're just not seeing it yet. All right. We're just about done on this side. You can see the epidural fat, a little bit of epidural vein right there. I'm going to zap it with the laser, see if I can get it to stop bleeding. And once you start getting that epidural vein bleeding, what happens is your visibility gets worse. You get this kind of haziness. It looks like a sandstorm. It's really just a little bit of blood in the water, but it does make a difference. I could turn it off again if I wanted to, by just putting the tube back inside a little bit more. Here's part of that tear we talked about earlier. The blue dye stains the nuclear material. All right. I know I got the giant herniation out, so I'm sure his leg is going to do better. I'm sure his back pain will be better. I feel really good about it. The herniation on the other side is not as big on the MRI. It's probably half the size. So we're just about going to wrap this side up in 30 seconds, and we're going to go to the other side. And we're going to finish the surgery after we complete the other side. Again, the blue thing is the laser fiber. There's a little bit of epidural vein. Here's the posterior ligament right here. I just want to make sure I get as much of this tear as I can. He's probably responding just a little bit because we're in the most painful part of the disc herniation right now. This outer part. This is where most of the most nerves are. This is where the patient's going to have the most discomfort when they have a herniation, right out here. Again, this procedure was created here at Duke Spine Institute, pioneered here. It's the only place in the world you can get it done. And that's why we have people from all over the world. This patient is from out of state. He's from Chicago, visiting us here in Florida to have his back fixed with his family. All right. And it is during COVID-19. We're still operating. We don't believe in withholding important life-giving care from patients because of COVID-19. We do all the screening. We don't have any infected patients here, but we also don't restrict people from getting fixed during the virus. So pain doesn't respect the virus. It doesn't go away because the virus is here. People still suffer every day, and our job is to get people out of the suffering so they're not suffering anymore. That's what we do. What's wrong? Luis?
Nothing's wrong, sir. He's gonna switch irrigation right now, sir.
All right, yeah, that's good because I'm pretty much done with this side. I'm getting ready to go to the other side. Go ahead and switch. Saw some fat globulets earlier. That's a big vein right there in the epidural space. Okay. I'm surprised I haven't seen the other needle yet. It's in here somewhere. I don't really want to hit it because if I do, it could melt the tip and I can't get the guide wire out. But I know it's in there somewhere. All right, I think we're done here. Laser off? Okay. So the good news is we're done on this side. Let me see if I can suck this tube dry and you guys, maybe we can see the nerve. The nerve on this side, the L4 nerve root. It's going to be right there. See that? It's in the foramen. Scope off. Medicine. Let's take this tube out, put a little bit of pressure here. Okay, give me that. Nice job. So what you're doing is you're actually applying pressure to the paraspinous muscles, you know? All right, so at this point, let's get our guide wire. Let's get our fluoro back in. Watch the scope carefully. I don't want to knock it off the table. Just go ahead and go back to a lateral. Here's another piece of disc herniation. Yeah. Come on. I said don't knock the scope off. Thank you. How come he's like listing on the table? Did we pat him properly? And he's even? I mean, because you can see he's right side up, unless he's got scoliosis. You guys made sure he's nice and even?
He was initially talking this way, so we
So maybe he just moved.
a little bit to get him straight, but
Maybe he just moved himself. All right, whenever you're ready. That looks good. Stay there. So, I'm going to show you in just a minute the incision that was made on the left side and show you where we did the surgery and how small it is, okay? Can you all see my hand down here?
Yes, we can.
Look how tiny this incision is. You see that right there? Half of the width of a dime. Did you see it? Hello, McFly.
Yes, we saw it.
Thank you. I can't read minds yet. Let me evolve a few more lifetimes. I wish I had a little bit more light over here. Anybody who cares? Don't lean over that. Watch your head. All right, so from now on, just to make it easy, that'll be your light. But I don't want you leaning over the table. I want you pulling the whole arm back towards you so it doesn't hit Cam in the head. So it's more over here, but aiming that way. Does that make sense? No, you don't have to. Right now, I don't mind if it hits Cam in the head. Okay, that was supposed to be funny. At least Cam laughed. Luis, I got a chuckle out of him. All right, shot. Okay, so we're coming down with the dilator once again at L4-5. And we're in the, just about to enter the foramen here. Now let's see where we are. We're working our way towards the back of the disc. That's a very nice job, Jordan, with the x-ray. Thank you. All right, so that's about as far as I can advance it without using the mallet. So I'm going to go ahead and use the mallet now. Yep, thank you for doing that. Perfect. Shot. There we are. Need to aim. Shot. Uh-huh. Shot. We okay here? Yeah. Nice and supple. So, I'm thinking that looks pretty good. I'm going to go a little more on the guide wire, and then I'm going to just shot, get rid of the guide wire, take that, mallet, perfect. Okay, nice job. Guide wires here. You want to always inspect these to make sure there's nothing bent. You know, a little bit is okay, but all right, we're in. Now we're going to bring, once again, I'll show you all. This is the tube we're doing the surgery through right here. So everything is put through this like metal straw, basically. It's a metal straw, but it's a very expensive metal straw. I don't set the prices, but these Germans love to charge a lot of money for their technology. But that metal straw is the whole surgery done through it. So I bring it down over the dilator. And how does it look? And of course we're using our x-ray machine, taking a picture from the side to guide me. Can't do this on feel. This has to be done with what we call navigation or x-ray guidance in this case shot. Now it looks like I've trapped some tissue between the dilator and the tubular retractor. Alright, that's good. So we're going to take the dilator out. What is that? Yeah, you want to put all that away from where you can mess it up. Shot. All right, let's see. It looks like that's the tip of my tubular retractor, so I think we're good. Don't try this at home, folks. I know we make it look easy here. All right, let's get that flow all the way out. I'm going to come over to your side. Will you push my stickies on my nose gently, because I just had surgery. A little, towards the skin, on the skin. Yeah, yeah. Towards the eye. Go higher towards the eye with your finger. There you go. Push it on my skin. There you go. So I can't, otherwise the hot air, I got a lot of hot air. Right, Luis? A lot of hot air. And it all comes out. All right, folks, this is it. We're going to get this side done and we'll be done. This will be probably 10-15 minutes. Everything okay, Luis? Yeah, thank you. Perfect. Perfect. Okay, so we've got our tube. We've got our fluid adapter is what it's called, and then we've got our suction line on there, which we don't turn on till the end. We've got our if you want to look here, I'll show the audience real quick, Sean. Let's get a light on. You looking through the eye in the sky?
Yes, I am.
All right, so you have the endoscope here, which is a rod lens scope with a working channel in the middle. You have irrigation right here, and when we turn it on, it squirts out the end. You have a light source here that provides the illumination at the end via fiber optics. You have a camera here with a camera cable. All right? Now you can do it at home in your garage, now that you understand what I'm doing. As long as you have Dr. Santiago doing the anesthesia, you'll be all right. Right?
Don't count with me on that.
Don't count on him being there, he said. All righty. So we're inside the disc. There's a piece of herniation right there. Grab her. And once again, remember, we've already taken the herniation off the other side. I'm sure there's herniation here because I saw it on the MRI. I don't think we're going to get a big chunk like we did last time. Take it. And of course, we're going to ooze because we've already done the other side, which is oozing a little bit of blood. So it's going to affect our visibility. That's okay. I'm not deterred. Fortunately, I've done a few of these, so I know basically what needs to be done. Grab her. Take. Any questions from our audience?
None others so far.
Anyone going to try this at home?
And for patients in pain, we'll allow somebody to try it, right? They don't have access to
To me?
you.
Well, it's a great question. course.
People in pain will try anything.
I understand. But that's where doctors are supposed to know the limitations of their ability. And of course, there's the non-licensed healthcare providers who think they're doctors, who don't know the limitations, who wanted to treat diseases even though they didn't go to medical school or study. In the end, folks, you want to go to a place where you're going to have a great result with a very successful surgery, and you're not going to have the complications that happen when the surgeon doesn't know what they're doing, or the anesthesiologist doesn't know what they're doing. It's very tight. Is he waking up or lighter?
I was just reaching propofol, but now.
No, he's still deep. He's not responding in any way here. I just thought the tube was tight. It's very odd. Maybe he's more collapsed on this side. This is his left side. A lot of scarred disc material here. This looks like a big herniated fragment to me. Just laying there, you know, right there. And there's another one right there. It's not that big, it's small. But it's going to come out. There we go. Standby laser. So these herniated fragments, they perplexed me for a while when I first did this surgery. I was wondering how could they be inside the disc? And then I realized, wait a second, I pushed them inside the disc, right, when I put the dilator in. So the great mystery revealed itself over time. I realized that I was getting these herniations inside the disc because I was pushing them in the disc, which is a good thing. It's part of the Tony Young technique. Tony Young is the spine surgeon who taught me a lot of what I know about lumbar endoscopic surgery. He's retired now. That's a piece of blood clot, by the way. He only teaches in China. His son, Chris Young, is still operating, but Chris doesn't like to do endoscopic surgery. Chris likes to do fusions. It's funny, because his dad is a pioneer in the United States of endoscopic spine surgery, but Chris wants to be like all those complex spine surgeons doing big deformity cases and fusions. Now, it doesn't mean he's not a good endoscopic surgeon. He is. He's learned everything his dad has done for years. But I think he enjoys the bigger cases like we did earlier, the ACDF 3-level reconstruction. He likes doing that kind of stuff. How's our patient doing, by the way? The last one. Is she doing better with her muscle spasms? Stand by. We're almost done. 5 minutes to go.
We have a question.
Sure.
One of our viewers is wondering, why did you choose to start your practice in Florida?
Why did I choose to start my practice in Florida? That's a great question. I don't think anyone's asked me that. I'm happy to talk about it. I am from California, from Los Angeles, San Diego area. I went to UC San Diego. I went to USC Med School in Los Angeles, University of Southern California. I'm a California boy. I grew up in California. I love California. But there's a reason I left. So I knew I wanted to be a neurosurgeon, and neurosurgeons have to be trained at an institution where they have a neurosurgery training program. And back in 1997, there were only 90 neurosurgery training programs in the United States, 90. And so I was the valedictorian of my medical school class, and I had done research. I was basically one of the most sought after medical school graduates in the country. And I knew I wanted to do neurosurgery, but I wanted to get the best education possible, like the best training. I didn't just want to go and sacrifice 7 years of my life living in the hospital, working, and come out and be mediocre. So I asked my mentor, Dr. Marty Weiss, who happened to be the president of the accreditation committee for neurosurgery residencies. He was a neurosurgeon himself at USC. He was the chairman at USC for many, many years. He was my mentor. And he told me the very best program in the country, in his opinion, was the one in Gainesville, Florida, under Dr. Albert Roten. He said that is where you're going to get the very best training. Second best would be Seattle, and then Michigan. So of course I interviewed at all those places, and they all wanted me to go. But in the end, I really liked Gainesville, and that was the one that Dr. Weiss told me was the very best. So the chairman really liked me, and he chose me, and I chose them, and I ended up in Gainesville. Now Gainesville, Florida has nothing, you know. I mean, it's this college town. It's got the Gators, and of course I really enjoyed it, but I had to move from California to Gainesville, Florida for 7 years of training in neurosurgery. At the time, I thought I would be doing more brain surgery, not spine. I had no idea I was going to do spine surgery. So I ended up there, and when I was there, I met my wife, who I'm married to. She's from Florida. So my plan was to finish my training and go back to California and live in California. As I started to get close to the middle of my training, I started coming back to California and looking at possible places to work in San Diego. And what I learned is that there were already too many neurosurgeons in San Diego, like a lot of them. And so I would be, you know, let's just admit it, I would be used and abused by the group that I joined. And I didn't want to start at the bottom. It was important that I could practice medicine and neurosurgery and use the skills that I had learned to the fullest ability. I didn't want to be held back by my partners because I was the fresh meat, so to speak, and they would be giving me all the surgeries they didn't want for years. So I chose to go somewhere I was needed. And this area of Florida was underserved. They needed neurosurgery badly. The hospital needed it bad, and 2 hospitals needed it bad. They both got together. They hate each other, but the one thing they agreed on is to bring a neurosurgeon. So I came here because I was needed here, because they didn't have enough neurosurgery. So what happens is when neurosurgeons graduate their training, they want to go live in the best cities. They want to live in San Diego, New York, Los Angeles, Beverly Hills. They all have the idea of going somewhere where, you know, they can have the best lifestyle, be in a big city. Of course, I wanted the same thing, but I didn't want to sacrifice my independence to be able to practice medicine the way I wanted to, and have to go to a big city as, you know, to sacrifice what, basically building my own practice and my own vision of how I wanted to take care of patients. So I stayed here, where nobody wanted to go. Brevard County. I mean, you ask me a question, I'm always going to tell you the truth. So people don't want to live here, you know. It's not sexy. It's not, you know, it's not New York City. It's not culturally at the apex. It's not Colorado, you know, Denver, or it's not one of those sexy places. But there's a need, and the patients here appreciate what I do. And of course I started local. I had no idea I was going to be treating people from all over the world when I came here. But once I learned this endoscopic surgery and I started to master it and improve it and make it better, then people found out about it, and the results, more the results than anything, and then they wanted me to to do their surgery, and basically we have people from all over the world now that come here. Did I expect that to happen? Absolutely not. When I went into neurosurgery at USC, when I went into neurosurgery in Gainesville, leaving USC, I was going to be a pediatric neurosurgeon. Everyone knows who Ben Carson is. Ben Carson? From Johns Hopkins. He is the African-American neurosurgeon who's in the news quite a bit. Anyway, that's what I wanted to be, was a pediatric neurosurgeon. That was back in 1995, 1996. So I went to Gainesville expecting to be a pediatric neurosurgeon, operating on kids with brain tumors, malformations, all kinds of stuff. And of course I did all that as a resident in Gainesville. I learned from some of the best pediatric neurosurgeon, Parker Mickle, trained at Harvard. He was one of the best pediatric neurosurgeons in the country. And he taught me how to operate on kids. He was amazing, very, very conscientious person, a great neurosurgeon, a bit of a pedophile himself, but always legal, of course. But he was always chasing the young girls around the college campus, even when he was in his 70s. But never mind that. The main thing is that he was a great neurosurgeon and did great neurosurgery on kids. So I had that experience, and in the end I did epilepsy neurosurgery as well, because that's common among kids. And I was really geared up to be a pediatric functional neurosurgeon in some university somewhere. And then I met a guy named Jeff Henn, and Jeff Henn was one of my faculty. He came from the Barrow Neurological Institute, considered one of the very best in the world in training in Phoenix, Arizona, the Barrow Neurological, and he was a spine surgeon. And he brought techniques to my residency program that no other spine attending was doing. And he was treating pain, and he was treating it successfully with fusions. And patients were in the hospital, though, for weeks after his surgeries. So I spent a lot of time with Dr. Henn and learned his techniques on how to cure back pain, how to cure neck pain with fusions. And then, of course, I did artificial disc surgery as well at University of Florida. And basically, after 2 years with Jeff Henn, I decided I didn't want to do pediatric neurosurgery anymore. I wanted to do spine. And I wanted to fix people's backs and necks, get rid of their pain. So I came out to Brevard County in 2004 when I graduated, started my own practice with the assistance of the hospitals, operated at the hospitals exclusively. And then after 3 years, my contract was over. They wanted me to resign. I didn't want to, because they're very controlling, and not in a good way. They don't help you. They actually hamper your practice. Standby laser. And so I decided to strike it out on my own with my wife. We started with our first employee, and then now we've grown to where we are now with surgery center, MRI, imaging, and our clinic, multi-specialty. We have about 35,000 patient visits last year, and we're doing great stuff. I mean, cutting edge, revolutionary stuff in spine surgery. So it's a dream come true, I guess. Maybe better than a dream, because I didn't even dream I'd ever be able to do this. This is better than any dream I ever had. We're curing pain, curing back pain, curing neck pain. And someday all these other surgeons around the world will be doing what I'm doing and curing pain as well. But unfortunately, that's a long way off. I have to get the word out to them, and they don't like listening. They've got their heads up their asses for the most part. That's where they're all comfortable being. Nobody wants to admit they don't know everything they should know or need to know to practice medicine. They don't like admitting their faults. For me to go out and learn this stuff from the Koreans and from the Dr. Young and the other doctors that trained me, I had to accept that I didn't know everything, and that there was this technique that I wasn't even exposed to really as a resident. And so for me, it wasn't a big deal. You know, there's something I've never done, big deal, I'll go do it. But for a lot of these guys that are neurosurgeons, they don't want to admit that there's something like this that they don't know anything about. So rather than admit it and learn it, they choose to ignore it. But by them ignoring it, they're not helping the rest of the world. They're not helping their patients. So I can fix their knowledge deficits with teaching. I can't fix their pride. Everything okay, Luis? I got 2 minutes. Hey, hello, wake up. You got to stay sharp, okay? That's all right. What is it, Luis? All right, good. We're just about done. I need 2 minutes maybe here, Dr. Santiago. So that's how I ended up in Florida. That's why I'm here. I have no family here initially. Now I do. Ever since I moved here, my sister moved here, my brother moved here, my mom moved here, my other sister moved here, her family and husband moved here. So basically everybody in my immediate family has now moved here. We all work together, not in the same business, but we have professions that complement each other. For example, Dr. Schrumpf is a nurse practitioner now, and she does primary care. She sees patients in our practice. Look at that little arterial right there. Pretty cool, huh? And she also heads up therapy, her therapy practice. They treat our patients after surgery. She's really the best therapist I've ever met. Physiotherapist, chiropractic therapist, basically. My other sister is an attorney, and her husband's an attorney, and my brother is a neurosurgeon in Tampa. And that's just the perfect distance for me, because his head is so big and my head is a little big, and I think we both meet somewhere in Orlando. He's younger, he's 8 years younger, but he thinks he knows more than I do. You know how that goes, right? Yeah. It wasn't always that way. He used to be humble and modest. 30 seconds. I tell you, when I was interviewing for residency, I was very tempted to go to Michigan. I was very tempted to go to Phoenix. I was very tempted to go to Seattle. I was very tempted to go to Johns Hopkins. They all wanted me badly. And in those programs, the residents, man, they treat the residents so well. I mean, I can't even begin to tell you. Really nice restaurants and dinners, and a lot of respect for the residents from the chairman and the faculty. But I chose to go to University of Florida. I should have known, because every other place I interviewed, they gave you a nice hot meal, but UF gave us cold sandwiches with white bread. And I chose to go there because of the training, even though I knew, and Dr. Friedman had a reputation there. He was the residency program director. They called him the Dark Lord, and he really was like Darth Vader. He was purely evil. He enjoyed inflicting pain and suffering. And I don't care if he's listening right now, he knows it's true. Now, in the end of the 7 years, he and I became kind of close, and I think changed how we thought about the residents quite a bit. But I have to admit, if I had his job, maybe I would be more upset with the residents too. Because some of them are real schmucks. They don't care about the patients. They make mistakes. They hurt people with their mistakes. And they don't seem to care or learn from their mistakes. So I could understand Dr. Friedman's frustration. Anyway, done.
Is it off?
We're all done, folks. I'm happy. We've got those roots decompressed nicely. Scope off. Any more questions? I want you to type them up for me. And I'll head over, watch that right there, and I'll head over to the conference room and I'll answer them for you, okay? Take that. Let me have a roll here. There we go. So we did both sides, L4-5, next to his prior surgery, which was done at L5-S1, where he had an infection. I did not do the old surgery, someone else did. And it just highlights that, you know, if you go to the hospital for your surgery, if you have these traditional open surgeries, the risk of infection is dramatically increased. We've had 0 infections with our Duke laser disc repair. I've never had an infection in 15 years of doing this surgery. 0. And we've never had a complication. No nerve damage, no CSF leak, no infection, no fractures, nothing. We do have recurrent disc herniation, 1%. And that's really the only bad thing about the surgery. It's outpatient. This patient will go home in an hour. All right, type up your questions. I'll head over to the conference room where Sean is, and I'll answer them for you. Thanks, everybody. Good work today.
All right, everyone, thank you for joining us for the post-op Q&A. We just wrapped up our last surgery of the day, which was a one-level Duke laser disc repair done bilaterally. We have Dr. Duke in the room with us ready to answer some of your questions, so I'll bring up the first one now. One of our viewers on Facebook is wondering, Dr. Duke, how can inflamed and swollen facet joints be treated? What are my best options? I'm having severe spasms in my back.
Well, thank you for all of you joining us today and during the surgery. I'm going to answer that question in just a minute. I just want to say thanks to Sean, and one more time, today we did receive notification from the governing bodies at the AAHC, which is the governing body overseeing accreditation of surgery centers for AAHC accreditation and Medicare credentialing or certification, basically. And every 3 years we have to be reevaluated per the laws and hopefully pass and be reaccredited. We just received our letter today that we've been reaccredited for 3 more years. That's the maximum. It's the very best you could do. On 850 core measures, we had only minor things like, one of the scoots around the water sprinkler for a fire fell out, and little things, very, very minor stuff, like tiny little things. But basically it's huge. Our surgery center did very, very well, and the nurse that came and the engineer that came said they've never seen a finer surgery center, and that's all they do is full-time going around the country and looking at surgery centers and trying to find things they're doing wrong so they could write them up for it. So yeah, I just want to thank everybody. Ann Caldwell, our director of nursing, she's done a fine job of running the surgery center. And then also, of course, Karen Foley for helping put together all the data, all the nurses and staff that work over there, all of the anesthesiologists, Dr. Patel, his team, my team. They've all done a phenomenal job. It's a big celebration. We don't have to go through this but every 3 years. And it's also very expensive to go through. For the nurse to come out for a day, normally nurses make $30 an hour, so you can imagine 10 hours times 2, 20 hours max, 30, $300, $600, plus an engineer, maybe another $400, $1,000. We pay $14,000 for the accreditation survey. So it's kind of an expensive endeavor, and I'm glad we don't have to do it again. But long story short, excellent news, and we're looking forward to another 3 years of successfully doing complex spine surgery and interventional pain management procedures. All right, getting back to the question, and the question was, I have inflamed facet joints, and it's causing horrible pain in my, I don't know if it's the back or the neck or the thoracic, I assume it's the lower back. What can be done? So, great question. Facet joint inflammation is a major cause of chronic back pain, meaning back pain that lasts more than 6 weeks. And there's actually quite a bit you can do for it. So, I'm going to assume for one moment that your diagnosis is correct, because I didn't give you the diagnosis. And I'm always very skeptical about people's diagnoses from other doctors. Most of the time, those doctors are wrong. And so let's assume for one moment that you do have facet joint inflammation, and that's the source of your pain. The best treatment in the world is a procedure called a rhizotomy. And once the rhizotomy is done, you want to start physiotherapy, and you want to start chiropractic manipulation. Now, there's a very specific set of exercises that need to be done to treat that inflammation in your facet joints and get rid of the pain. So what happens is the rhizotomy is a procedure where we put a needle right where the nerve is that goes to the facet joint that's inflamed and causing pain. That nerve is called the medial branch of the dorsal ramus. And by putting a probe right there on that nerve, a procedure called a rhizotomy, we can turn the probe temperature up to 80 degrees Celsius at the tip. That kills the pain nerve to the joint. So basically that takes the pain away by killing the pain nerve to the joint. The nerve will grow back. It takes about anywhere between 3 to 6 months, maybe a year for it to grow back. So the procedure itself, the rhizotomy, is not a cure in general, but what it does is it allows the patient to have the pain from those joints gone for about 3 months, And during that 3 months, and this is where most everyone fails to complete the treatment, you need to get specific chiropractic manipulation therapy and physical therapy. So that's what we team up with a company called Florida, what are they, Florida Sports and Spinal? Yeah, Florida Sports and Spinal. And they are the therapy group that treats all of our patients with facet disease, facet inflammation. And it's important to get about 6 weeks to 8 weeks of facet joint treatments. And what the treatment does is it breaks up the scar tissue in the facet joint that comes from the inflammation. So the chronic inflammation causes pain, but it also creates scar tissue. Like you saw today with the ACDF, you get a lot of scar tissue. Also with the disc herniation that we just did, there was a lot of scar tissue there. That chronic inflammation that causes the pain creates scar tissue. The scar tissue then, as you move, your facet joints move with respect to each other, they actually rip the scar tissue and cause more pain. So there's a cycle of inflammation from tearing the scar tissue to healing and inflammation. So the best treatment is rhizotomy plus the appropriate facet joint therapy. If that doesn't work, the next best treatment, unfortunately in this day and age, is a facet joint osteotomy where you take the arthritic joints out and then fuse with screws, rods, and cages in the lumbar spine. So that would be the backup plan if the facet joint rhizotomy doesn't work. Now, there is one more thing you can do, and it is putting PRP or stem cells into the facet joints. There's not a lot of places you can go to get that done. So you need a doctor who knows how to do stem cells or PRP. So that's what I would do before the fusion if it was my back. I would do the rhizotomy first with therapy. If that fails to give me the relief I'm looking for, I would do PRP stem cell injections into my facet joints. If that doesn't work, then I would do a fusion with osteotomy. Now, of course, who does all these things the best? Duke Spine Institute. Can you get it done somewhere else? You're probably going to end up not getting the very best, and you may fail to improve, not because you were not improvable, but because you didn't get the right treatment done. Having the rhizotomy done properly requires not just excellence of technical technique, but also you have to have the right equipment. A lot of places don't have the best x-ray machines to see the needles. They don't have the best rhizotomy machines. They're always coming up with new ones every few years. We use the very latest and best ones. So what I'm getting at is you could have facet joint arthritis that if you do the rhizotomy it doesn't get better, or you do the therapy it doesn't get better because the rhizotomy wasn't done right or the therapy wasn't done right. My advice, go to some place that knows what they're doing and they do it right, like Duke Spine Institute, and that way you know you've gotten the very best treatment. So if it fails and you escalate to the next level up, which will be your PRP stem cell or the fusion, you know that you've given yourself the best chance of avoiding those more expensive or more invasive treatments. But I would also caution you, one last note, that don't believe that you have facet joint inflammation arthritis unless it's confirmed. And again, just as Duke Spine has technical excellence over everyone else, we also have diagnostic excellence. And making the right diagnosis is so important. I see a lot of people out there who've been given the wrong diagnosis about their back pain, and they get the wrong treatments or they get no treatment at all. So it's important to get the right diagnosis first and foremost. That was our only question. So I hope you enjoyed the bilateral Duke laser disc repair, L4-5, in this patient who's a physician, a doctor from Chicago. And we'll check with him tomorrow in clinic and see how he's doing, and we'll broadcast that video.